Morning from Colombo, Sri Lanka. This is Dr. Pamod Damrikon, representing Health Informatics Society of Sri Lanka. I would like to warmly welcome all of you around the globe for the special 18-hour G2MC Grand Rounds. Rapid advances in genome sequencing technologies, bioinformatics, and computational biology is heralding an era of genomic medicine. The series of lectures conducted by the Global Genomics Medicine Collaborative, supported by the Health Informatics Society of Sri Lanka and the Asia eHealth Information Network, will showcase some of the pioneering initiatives in genomic medicine from around the globe. This series would be co-hosted by Professor Bruce Koff from University of Alabama in Birmingham, United States, and Professor Vajra Disanaike from the University of Colombo, the co-chairs of the Education Working Group of G2MC. Before moving on to today's session, I'll briefly mention a few things to remember while using WebEx platform. Once you have logged into WebEx, the left panel is where you shall see the content presented by the panelists, including PowerPoint presentations, videos, etc. The right panel contains some useful tools. If you click on Participants icon, it will display all panelists and attendees currently logged in to the event. Q&A button can be used to ask questions from the panelists. You can also provide feedback during the presentation by clicking on the close, yes, no, too fast, too slow, and laughter buttons. Please note that your microphone will be automatically muted once you join in as an attendee. If you encounter any issues in receiving audio during the webinar, please log out from the WebEx platform and try to re-log in. With this brief introduction on WebEx, I would like to invite Professor Vajra Disanaike, the co-chair of Education Working Group of the G2MC, to moderate today's session. Over to you, sir.
Morning from Sri Lanka, and wherever you are, maybe evening or afternoon. Welcome to the first webinar organized by G2MC. This morning we have Professor Bruce Koff from University of Alabama in the USA to talk to you about UAP's Undiagnosed network program. Before Professor Koff comes online, we would like to introduce G2MC to you. G2MC is a global collaborative that is being coordinated by the Institute of Medicine of the National Academies of Sciences of the USA. It was inaugurated in January 2014 in Washington, and the collaborative has been meeting regularly for the past 2 years. The Education Working Group is pleased to introduce this series of grand rounds, where we will showcase various initiatives around the globe on implementation of genomic medicine. So without further ado, may I now hand over the mic to Professor Bruce Koff to talk to you about their program at the University of Alabama. Over to you, Professor Bruce.
So I guess I need to share my desktop, so just give me a moment to get it prepared. Okay, well, thank you very much, and it's a great pleasure to have the opportunity to participate in this event, and very much look forward to conversation as we go on through the presentation and to future presentations of this group. So I'm going to talk about a program that we have had up and running at University of Alabama at Birmingham for now about 2.5 years, that is modeled on a program of the same name that was initiated by the NIH, which I'll say more about in a moment. But just to get it started, let me present a case to you, which actually was the very first patient whom we saw in the program when it launched in 2013. A boy who at the time was 20 months of age and had a birth weight in the 5th approximately centile, small head at birth, had some problems in the early newborn period and was noted to have microcephaly. It had a brain MRI that showed hypoplasia of the cortex, but also especially underdevelopment of the cerebellar vermis. At 2 months, he began to have infantile spasms and had a lot of standard testing done, which you can see listed. I won't read it all to you. None of that revealed an abnormality that was felt to be pathogenic. There was a deletion on the X chromosome, but it was deemed to be a variant of unknown significance. He went on to have epilepsy that was very hard to control, cortical blindness, hearing loss, and a number of other problems, as you can see. He did not have a family history of similar problems and had some additional genetic testing using panels both for microcephaly and pontocerebellar atrophy, and nothing was found with any of these. This is an example of his MRI scan. You can see the very significant hypoplasia of the cerebellum and also of the pons, as well as some degree of cortical atrophy. So this was the first, actually, and indeed a fairly typical kind of problem that we were faced with, namely, in this case, a child who had multiple problems that had pretty devastating effect on function, and in spite of a lot of effort, no idea as to why this was happening. So what I'll try to do is set up a rationale for the formation of the program, tell you a little bit about the people that we work with and how we've set it up organizationally. Much of what I'll talk about will be some case studies to give you some examples of cases that we've been involved with, and then a few words at the end about where we would like to go with this. So as I mentioned, the program is modeled by one that was initiated at the NIH now several years ago by Bill Gall, who is at the center of this picture. Many of the specialists who work with him are shown in the sort of circles around him. The program has done a remarkable job of helping to sort out the underlying pathogenesis of very complicated chronic problems. It has expanded into a network, and we at UAB are not part of that network, but our institution became intrigued with this model and provided us funds that allowed us to set it up independently at UAB. So the program, as you can see, launched in October of 2013, so it's been going now for about 2.5 years. These are the current staff who are working in the program besides myself. Maria Descartes is a pediatric geneticist, and Martin Rodriguez is an infectious disease specialist in internal medicine. Not all of the patients we see necessarily have what we think are genetic problems, and indeed many of the diagnoses made are of non-genetic disorders. We have 2 nurse practitioners working in the program and also a genetic counselor. In addition, we have a group of both pediatric and adult specialists who work with us and meet every other month to review cases that are pending, but of course are involved on a much more active basis from day to day, agreeing to see patients whom we refer and also helping to review records for us. This is a chart showing the workflow. All patients must be referred by a physician, so we don't accept self-referrals. We do an initial review, and if we decide that the patient fulfills the criteria for involvement in the program, which I'll show you in a minute, then our nurse will collect records. We'll then review those in some detail and often pass them to some of our specialists for their opinion. A final decision will be made, again, you'll see the criteria soon, on whom to bring into the program. And then once that's done, an evaluation gets scheduled, then ultimately gets done. We engage various consultants, and finally, when all is completed, we provide feedback both to the referring doctor and to the patient. Referrals can be done using an online form. This may be a little hard to read, but it is a relatively brief, simple form that physicians would fill out in order to refer a patient. So these numbers, as you can see, are not completely up to date. They're about 6 months out of date. That was the last time we did a really careful tally. And as of that time, we had about 200 patients who had been referred. Some of them, about 10 at that time, were still in process of trying to decide whether we bring them into the program or not. You can see that about 15% were referred to alternative programs. Sometimes when we review records, it's pretty obvious that the nature of the problem is best handled by, let's say, neurology or by infectious disease or whatever, and so we'll refer them appropriately. A few of them, the patients decided not to proceed. So about half, 91 at that time, had been evaluated. About half of those workups had been completed, and about half of those we achieved a diagnosis. There were many at that time that were still in evaluation. Obviously, these numbers have changed in the months since, but the general sort of trends are about the same. So why would we defer a patient? We require that there already would have been a extensive evaluation done. So we're not expected to be the first stop of where a patient would come. And sometimes we come to conclude that we just don't have anything to add, that everything we could imagine being done, including sometimes genome sequencing, has been done. We have criteria that include that it be a significant disability resulting from the disorder, and that the duration be at least 6 months. So we're not really designed to be an acute care kind of program. So it really is intended for chronic disorders. Sometimes we don't get the documentation to be able to make a judgment. Sometimes we'll make recommendations to the referring doctor, but they'll decide they can fulfill those and it's not necessary for us to see the patient. Sometimes people ultimately decide not to go forward, and occasionally it's taken a while to get in and people find another facility that can accommodate them. Not everybody has, as I mentioned, a suspected genetic problem, but of course, for those that do, where we think there's a possibility of a genetic answer, everybody gets a cytogenomic microarray, everybody in that category, I should say, looking for copy number variations. The case that I started with, as you saw, had one, but it resulted in a variant of unknown significance, so we did not feel that a diagnosis was made. And I'm sure this is a familiar curve showing the reduction in cost of genome sequencing. I'll tell you that when the program started, so that's 2013, we were doing exome sequencing, and we worked closely with the Hudson Alpha Institute for Biotechnology in Huntsville, Alabama, who in this past approximately year have stopped doing exomes and now do whole genomes. So during this past year or so, we've worked with them and we're doing whole genome sequencing. Not always, because not every patient, as I mentioned, has an apparent genetic disorder, but as a very common sort of outcome. So let me return to the case that we started with. Remind you just briefly, it's a young child with intractable seizures, intellectual disability, and underdevelopment of the cerebellar, vermis, and pons. And so in this case, exome sequencing was done. It was early in the program. And interestingly, we found 2 de novo variants, a variant which consisted of an internal duplication within the SP10-1 gene, and a second variant consisting of a single base substitution in SETD5. Both were de novo in this child because we did sequence both parents. So SP10-1 is a brain spectrin which has been associated with the syndrome of infantile epileptic encephalopathy type 5, And in fact, the exact same mutation found in our patient has been described in other people with this same phenotype before. SETD5 is a domain of a methyltransferase, and it's been associated with autosomal dominant intellectual disability. This is, once again, the MRI of our patient. This is an MRI in a published case of SPTAN1 mutation. Actually, our patient's more profoundly affected, but you can see also the cerebellar hypoplasia and some degree of pontine and cortical atrophy. So we feel pretty strongly that the SPTAN variant is the pathogenic variant in this case, based on the fact that, as I mentioned, the exact same mutation has been published in other affected individuals. We're not sure what the SETD5 mutation is contributing. It would be difficult to judge about intellectual disability given the profound CNS anomalies. But in any case, this, we believe, is the pathology of this, or the etiology of this child's problems. It's not a treatable disorder, unfortunately, but the good news to the family is that it does appear to be a new mutation, and so the recurrence risk to the couple is low. Here's another example of one of our earlier cases. In this case, a SIB-ship of 3 out of 5 with a polyarticular juvenile arthritis, as well as mild to moderate intellectual disability, avascular necrosis of the femoral head, which you can see here. Again, they had been through multiple rounds of evaluation in many different places, and no diagnosis had been made. They were under treatment with anti-inflammatory drugs, but really not responding particularly well. And their mother had some orthopedic problems, though not nearly as profound as the children. Well, in this case, we found this GNPTAB mutation. Each of the 3 children was compound heterozygous for 2 different mutations, an amino acid substitution inherited from the father, and a frameshift mutation inherited from the mother. So what is this gene? Well, it's the N-acetyl glucose phosphotransferase enzyme that is involved in putting a tag onto proteins that will be transported to the lysosome. So in the absence of activity of this enzyme, the enzymes that would normally be sent to the lysosome instead get sent from the Golgi to be exported from the cell. And this is characteristic of mucolipidosis type 3, which includes a dysostosis multiplex, short stature, osteoporosis, mild intellectual disability, and sometimes cardiovascular disorders. Once we knew this finding, we actually arranged for genetic testing, for biochemical testing, and our own lab actually does it. And sure enough, all 3 SIBs had massive secretion of lysosomal enzymes into the bloodstream, and made a diagnosis then of mucolipidosis type 3. Now you could say in retrospect, well, this is diagnosis that could have been made clinically, and we would have been able to do the enzyme test in the blood and prove it. So you might argue that the sequencing was unnecessary. But the reality is it's an exceedingly rare disorder that I hadn't seen before, I'll tell you, and they had seen many other people, including geneticists before, who also didn't think of it. I would suggest that this is the kind of diagnosis that maybe if they had seen just the right person, maybe it would have come up. But it is an obscure diagnosis that literally nobody thought of. Interestingly, too, once we knew what this was, could judge that it was not going to respond to anti-inflammatory treatment, and they were switched to bisphosphonate treatments that are doing much better with less bone pain. They were prone to fractures before, which isn't happening. They even are arguably at least feeling better. Some of the family members feel that they're actually intellectually better off, but although I wouldn't have predicted that this would have an effect on intellectual function, it may well have an effect on sense of well-being. So it really did change the management of this family. Here's another case that was one of our early ones, a young boy with an acute life-threatening event in his first 3 days of life. Microcephaly, developmental delay, white matter densities, left hemispheric atrophy, and poor encephaly. Although I'll tell you, the poor encephaly was not evident, at least obvious, at the time when we first saw him. And we had to go back through the records and old MRIs for that to become clear. Apneic episodes, vocal cord dysfunction, bilateral cataracts, 46XY, 47XYY mosaicism, which we believe to be an incidental finding, since the phenotype isn't what you expect for XYY. Because of the cataracts, the idea of congenital infection had been brought up many times, I guess also because of the periventricular white matter densities, and that had never been able to be proved. So here's a screenshot of imaging from this child, and you can see the distortion of the lateral ventricle on the left side here, as well as, of course, pretty profound cortical atrophy. This child is the only affected member of the family, both parents well, and there are 2 healthy sibs and no previous family history. Well, here we found a de novo mutation in COL4A1, a predicted pathogenic mutation consisting of an amino acid substitution. COL4A1 is a subunit of collagen and is associated with neonatal or even prenatal stroke and poor encephaly. Once again, a diagnosis you might argue that could have been thought of, although I'll tell you that by the time we saw this child, the poor encephaly had really kind of gotten forgotten. And what we mainly were told was a child with developmental disability, atrophy, and seizures. Now, again, not a treatable disorder, although I guess he was making some developmental progress. And the good news to the family was that we didn't find something that guaranteed that this child wouldn't develop. It looked like a isolated, one-time, pretty devastating event, to be sure, but not a recurrent or ongoing problem, although, of course, he is at risk for additional vascular events. This is a summary, and it does include cataract and a leukoencephalopathy with white matter densities as a component of the phenotype, so it fits pretty well. Another case, this is an adult. Actually, you can see that the proband was a female in her 30s with weakness that had been thought to be some kind of either Charcot-Marie-Tooth or limb girdle dystrophy, brachydactyly, which is pretty evident from the photograph, joint pain, swelling, and her mother and half-brother also were affected. Sequencing demonstrated a TRPV4 mutation. This is a calcium channel gene. It's an amino acid substitution that has been previously reported to be pathogenic, associated with distal spinal muscular atrophy or hereditary motor and sensory neuropathy type 2C, and in fact also known to be associated with the skeletal dysplasia, including brachydactyly. Usually not both in the same person, but there are reports where that does happen. And this was found in the other affected members of the family. And actually, hearing loss can be a component of the phenotype. They were tested for that and actually also found to have hearing problems they were previously not aware of. Here's a recent case that of a young woman in her 20s who had developed fevers that at first were attributed to a viral infection, then was treated for asthma and was having chronic lung problems, continuing fevers, breathing problems, and then ultimately was admitted to the hospital. So these are laboratory studies, and my colleague, Martin Rodriguez, who I mentioned earlier, was impressed with the fact that there were no monocytes. I must admit that I'm sort of not in the habit of looking carefully at monocyte counts, but that impressed him, and it led him to send a genetic test. It was sent to an outside company. This was not a case that was sequenced. And the company returned two results. One was ASXL1, which was a nonsense, likely pathogenic mutation, but the allele frequency was only 13%, which made it seem like a probable somatic mutation. And then a GATA2 mutation, which is a missense mutation, known to be pathogenic, and in 53% of the alleles, although it was listed somewhat puzzlingly as a variant of unknown significance. Didn't make sense to me, actually, why it was a variant of unknown significance if it's of known pathogenic nature. And the answer turned out to be that the company is a company that basically does cancer testing. So they assume that every sample they get is a cancer sample, and they just didn't know what to make of a sample that would have a GATA2 mutation in a cancer with that high an allele frequency. But in fact, when I explained that they were looking at germline DNA from blood in somebody not known to have cancer, they agreed that this is indeed a pathogenic mutation. So GATA2 is a zinc finger transcription factor involved in hematopoietic and endocrine cell development. Germline mutations are associated with various phenotypes, one of immunodeficiency 21, also known as monomax syndrome, which I'll say more about in a minute. There's Emberger syndrome, which is lymphedema and myelodysplasia, and then familial myelodysplastic syndrome, or AML. And there are somatic mutations associated with AML or CML. This is a screenshot from ClinVar showing the specific variant and its reported pathogenicity. This is actually a screenshot from a published paper, and the circled variant here is the same one found in our patient, that therefore has been reported before as pathogenic. So what is monomax syndrome? Well, it's monocytopenia, so it was a great pickup by Dr. Rodriguez, recognizing that decreased NK and B cells, disseminated non-tuberculous mycobacterium infections. And it turns out she actually did have lesions that after the fact were biopsied and found to be atypical mycobacteria. You can have an alveolar proteinosis, various viral infections, and there is a risk of various forms of myelodysplastic syndrome or leukemia. The ASXL1 variant that encodes a polycomb family of chromatin binding proteins, or it's a member of such a family, so involved in chromatin remodeling or epigenetic regulation of gene expression. It's found in some myeloid neoplasms and in myelodysplastic syndrome associated with an adverse prognosis. And it may be found in the absence of hematological malignancy, mainly in elderly people. Now, this patient doesn't have a known malignancy at this point, although you could argue there may be a smoldering pre-malignant state given the ASXL1 variant. She's now, I believe, at the NIH being treated. They have a special program for this exceedingly rare disorder. Like others who do sequencing, we do come across examples of variants of unknown significance. Here's a young boy born with non-immune hydrops, bronchopulmonary dysplasia, pulmonary hypertension, rickets, and periventricular leukomalacia. Had a sibling who died of non-immune hydrops as well, and chylothorax. So it seemed possible that this was something that the sibling also had. And in fact, both parents carried mutations that possibly could be pathogenic in the PISA1 gene, so making this possibly a autosomal recessive trait. Problem here is that this is a mechanosensitive ion channel. It's known to be involved in prenatal vascular development, which could be appropriate given the non-immune hydrops. Problem is that pathogenic mutations described so far are gain of function, not as these would be loss of function, although in a mouse model, loss of function homozygotes are lethal, and there is abnormal vasculature. So this seems like a plausible candidate for the phenotype, but not yet proven. And we actually have been trying to collaborate with a lab that does research in this area, hoping that we can document the true pathogenicity. So again, we do find our share of variants of unknown significance, and the usual approaches for trying to determine whether they might really be pathogenic are available to us, and yet you do sometimes hit dead ends. We are interested in building a functional genomics pipeline in our center that will allow us to put some of these variants into model systems and see if we can replicate the phenotype. We're also in the process of joining through the Matchmaker Exchange system so that we can share genotypic and phenotypic data. That'll be particularly valuable for the variants of unknown significance, since if others have found similar variants, it helps us to recognize the true pathogenicity that may be associated with these. So where are we going with this program? It is our plan to expand it. We're opening up clinic space in Children's Hospital of Alabama very shortly, and we expect to expand our pediatric presence there. As I mentioned earlier, we collaborate closely with Hudson Alpha Institute for Biotechnology. We have a kind of a complex of clinics powered by Hudson Alpha, UAB, and Children's of Alabama, including a clinic in Huntsville, as well as the UAB clinic and the Children's of Alabama clinic. As I just mentioned, we're interested in building a pipeline for functional genomics, and we'll be engaging in data sharing as soon as we can work out the logistics and the consent process. What I call push diagnosis is, if you think back, for example, to the first case with pontocerebellar hypoplasia, that MRI is not unique. I've seen others like it, and I'm sure radiologists and child neurologists have too. And it's an exceedingly rare, I think, and obscure disorder, but who knows whether maybe there are other people out there that have never been diagnosed just because it's such an obscure condition. But now, knowing that it can cause this phenotype, we're thinking of going back to radiology and saying, show us your other MRIs that also have pontocerebellar hypoplasia in a young child. And maybe they should be tested for the same genetic change, because it may not be as rare as we think. And we're putting together also a database and biobank that will allow us to save tissue if it's available, DNA, and we're also interested in developing induced pluripotent stem cell lines from our patients so that they can be made available to researchers to help to sort out some of these phenotypes and underlying biological mechanisms. So I'm going to end with a few acknowledgments to the core team, whose names I mentioned at the very beginning of the presentation. We have a set of pediatric and adult consultants. I didn't name them, but there are many who have been donating their time to this. Hudson Alpha, where the sequencing and analysis is done. UAB Medicine provided support. And we've had, as you heard, many patients whom we've been working with now for this past 2.5 years, and who have entrusted in us the kind of effort of trying to sort out what the underlying pathogenesis of their disorders are. So with that, I think I'll conclude the presentation and be happy to entertain questions if anybody has. Thank you.
Thank you, Bruce, for that very interesting presentation. We have a few questions participants have posted, and let me read out those questions.
Sure.
What would be the cost associated with testing? Is one of the questions.
So right now, the cost of doing a whole genome at Hudson Alpha is about, I think, $1,500 for the sequencing per individual. So that means about 4,500 for a trio. Now that does not include analysis, but we work with Greg Cooper at Hudson Alpha, and right now we're doing these on a research basis. So we're not paying for the analysis, and we also have a pipeline that we can use. So right now we're paying $4,500 for trio on a research basis. Now Hudson Alpha does offer sequencing on a clinical basis, which includes analysis, and that costs, I think, about $6,500 or something close to that. So it's not an inexpensive thing, except if you consider the cost of MRI and other tests they're likely to have had. It's actually not so out of the range of what other medical tests might cost.
Thanks. Another question is, what is the process of a person getting referred to your program?
Well, so the referrals happen by doctors who recognize, a person with a chronic undiagnosed disease where they think that the kind of services we offer may be helpful. They can use our website. We do have a website where referrals can be made directly on the web, and that information goes to our nurses, or they can get in touch with us by phone, email, so pretty much various ways. But excuse me, as I mentioned, we don't take referrals directly from patients, so those referrals need to come through a physician that's working with them.
What are the activities of G2MC targeting enhanced genetic testing in Sri Lanka? I think that question probably I should answer. Yeah, we are collaborating with G2MC to, improve capacity in Sri Lanka, and at the moment we are setting up genomic medicine facilities in the University of Colombo, and these services can be obtained through the Human Genetics Unit at the University of Colombo. So you can, need be, contact the Human Genetics Unit to obtain those services. I was interested in asking you about how you deal with variants of unknown significance, because that is a problem that we deal with all the time, particularly when we do exome sequencing in Sri Lankan populations. We find that our variants are not represented in the databases.
Right.
So do you encounter that type of problem? I'm sure like you get patients from different parts of the world and different ethnicities who are really not represented in the databases at the moment. How do you deal with it?
Well, we definitely see, a fair number of variants of unknown significance. And, those typically are variants that are not found in any of the databases. The ethnicity of people whom we've taken care of are, pretty varied. It's a diverse population in the region, and there are people who travel some distance to see us. So, it's possible that part of the problem is that they're from ethnicities that are not represented in sequencing databases. I think probably that's less of an issue for us than it probably is in other parts of the world, because many of the ethnicities that we're most likely to see have been pretty well characterized. But when all is said and done, you are very commonly left with a variant. You have to make a judgment whether it is or it isn't pathogenic. So it's not always so easy. Occasionally, it's pretty obvious pretty quickly. Much of the time, we have regular conferences where the bioinformaticists and clinicians get together, and we just kind of debate about, is this or is it not real? We feel pretty comfortable when it's a loss of function mutation, and especially if it either segregates with disease, like we have seen happen, or if it's the same variant that's been reported before in other people, or the gene has been reported with the same phenotype in other people. But there are plenty of examples. The PISO mutation I showed you is a good one. It seems like a pretty compelling case. It should be pathogenic. but it's never been reported before in this way, and therefore it's hard for us to prove that.
Thank you, Bruce. I see the participants, and I see lots of biomedical implementations in the participants list. And from their point of view, I'd just like to pose a question. Would you know what bioinformatic tools that your bioinformatician may be using to predict function?
Yeah, actually, so the group that we work with on this is at Hudson Alpha. It's Greg Cooper, and the major tool he uses is the CAD score, which I admit I don't remember what it stands for, but what it actually is a measure of evolutionary conservation across the genome. They use, the various other, polyphen and so forth that everybody uses, but the CAD score actually was developed by Greg and his colleagues when he was at University of Washington, and actually has proved to be a very powerful sort of indicator. So I know that's the kind of major, sort of guide that they use. They have a whole team of bioinformaticists, and they use a variety of tools, but this one probably more than any other.
Thank you, Bruce. At this point, I'd like to acknowledge the presence of Professor Robin Ward, the co-chair of the G2MC, among the participants in this webinar. Professor Ward, we are going to convert you into a panelist so that you can participate in the discussion. So your status on the screen will change soon. Bruce, Robin has posed a question, which is, do you have a program set up to determine the functional significance of variants of unknown significance? Alternatively, are they on a callback program?
So right now, the only approaches we've been able to use have been to try to explore whether other members of the family, if there are affected members of the family, and occasionally that's proved to be helpful. But we otherwise don't have a formal functional genomics program. We have, where appropriate, sought colleagues or collaborators, anywhere, not just at UAB, who can help to sort this out. But we are in the process, we have the facilities set up, zebrafish or mouse models or even Drosophila and yeast. And we actually are in process of trying to set up a functional genomics pipeline to help to characterize these variants of unknown significance, but that's not yet up and running. So everything is done on a sort of collaborative basis with an investigator who is already involved in that area up to this point in time.
Thank you, Bruce. Robin, you are also on the webinar now, and we've unmuted your mic. Would you like to say a few words and also ask any questions from Bruce?
Thank you very much. So, thank you both to Bruce and yourself for inviting me to say a few words about the Global Medicine Collaborative, which is essentially chaired by myself. I'm an oncologist here in sunny Brisbane in Australia, and Jeff Ginsberg at Duke University. And the Alliance was set up, I don't know whether people on this webinar know about the Alliance, but it was set up to try and accelerate the implementation of genomics medicine into clinical care. It's only been in existence a relatively short period of time, only the last couple of years, and kicked off with a meeting in Washington. And then over the last couple of years, it's basically been running through a series of working groups, driving various aspects of the implementation agenda. And one of those is this group here that you're seeing the fruition of their efforts, this education group who has launched the grand rounds today, which I think is just an amazing accomplishment given the distance and all the other obstacles that you need to overcome. But congratulations to the working group and to you, Bruce and Vijara, for pulling this off. It's just fabulous. The other groups, for the people on the webinar who might be interested, there's one working on evidence guidelines, another on IT and bioinformatics, the pharmacogenomics group, and a policy group. Each of those are in various stages of activity, some more developed than others, but by and large are making progress along that implementation agenda. I think one of the important things to mention this morning or this afternoon is that the G2MC and the Global Alliance, the GA4GH, for Genomics and Health, recently held a meeting in Kyoto at another genomics meeting to work out how we could work more closely together. And it's very clear that there's lots of synergies, lots of complementarity between the two groups, and we've followed up with some important, I think, action items in the last couple of weeks, and as recently as this morning, about how we can better pool our energy and effort into joining up those two groups in a more systematic way. And I think one of the first sort of areas that we've identified is in the IT and bioinformatics, and I think we're going to see some exciting things happening out of that initiative over the next couple of months and year. Finally, just to conclude, I'll put in an advertisement for the G2MC's planned meeting next year in April in Athens, and that's looking like it's going to be another exciting meeting, probably following the same sort of agenda items that we used for the Singapore meeting held this last year. So for those of you who were not able to attend the Singapore meeting, we'd really love for as many people as possible to come to the meeting in Athens. So once again, congratulations on getting this great Grand Rounds off and running, and for presenting such interesting cases in the course of the last hour. So thank you, Vijara and Bruce.
Thank you, Robin. We have a follow-up question, which basically is asking us what we plan to do in the future, and also whether we'll be sharing these presentations. So yes, we plan to do. The Grand Round today was recorded, and future ones will be recorded, and they would be posted on the web. We will share with all the participants where we post it and how you could access it. The future programs will focus on different areas on genomic medicine, as well as it will also look at genomic medicine education and bioinformatics. So there'll be a mixture of different variety of presentations in these Grand Rounds. And I think, collectively at the end of the day, there will be Grand Rounds which focus on your area of whatever specialization or special interest. So therefore, I think by participating in the Grand Round, you would be able to get a broad overview of genomic medicine, the current status in terms of the state of the art, as it were, as well as specific input on the areas that you are interested in. And we would be happy to get feedback from you about what type of Grand Rounds you would like us to have on this series of Grand Rounds. So please do share your ideas with us, and we would be happy to cater to the interests of those who are participating. So with that, I would like to wind up today, because we've just come to the end of the 1 hour that we had. So I'd like to thank my co-chair, Bruce Koff from the University of Alabama, for coming forward and kicking off the Grand Rounds. We hope to have the Grand Rounds every month, on the first Wednesday, targeting Asia. So for the US and North America and South America, it would be day before. It would be the Tuesday in the evening and night. But for Asia, it would always be the first Wednesday of the month. And so with that, I would like to wind up this grand round and invite you to join us next month on the first Wednesday of the month. Goodbye.